Welcome to Ingest, the podcast series designed for primary care clinicians and brought to you by the Primary Care Society for Gastroenterology. My name is Charlie Andrews. I'm a GP with an extended role in gastroenterology based near Bath. This podcast is designed for educational purposes to help you develop your understanding in various topics in gastroenterology. It's not designed to replace your clinical judgment or national or local guidelines. In this episode, I'm going to be talking to Rick Fijten and Kosh Agarwal about viral hepatitis C. Rick is a GP in Southeast London. He has an interest in gastroenterology and education and is current hepatitis C GP champion in the Southeast London area. Kosh Agarwal is a consultant hepatologist and transplant physician at King's College Hospital in London, and he is the lead for the regional viral hepatitis programme at the largest treatment centre for viral hepatitis in the UK. So Rick and Kosh, thank you so much for joining me today. It's great to have you on the podcast.
Thanks for having us.
Thank you for having us.
So Rick, to kick us off, can you tell us, with your GP hat on and with your hepatology hat on, why should our primary care audience be interested in this topic?
Yeah, absolutely. So I think it's really important for a number of reasons. I think within primary care at the moment, we are under huge amounts of pressure, managing lots of complex chronic diseases, which a lot of the time we can improve, but we can't completely cure or resolve for patients. And I think what I've learned through my role so far as hepatitis C GP champion is this is a disease which is, with new treatment available, curative. And I think that as a GP is really exciting, because I think if we can identify these patients, we can get them on the right treatment, and actually the outcomes are fantastic. I also think, as GPs, a lot of our work is focused on improving health outcomes in patients who are from low-income backgrounds and from high areas of deprivation. And we know from the data that hepatitis C is more common in these patient groups. So I think it's really important for us to be thinking about this when we see people from these backgrounds, so that we can offer screening and testing and then treatment. So yeah, I think those are the two main reasons, but I think Kosh also wants to come in there.
No, I think it's a really good answer there from Rick, and thanks for having us, Charlie. For me, this is a success story for the UK and England particularly. And as Rick has said, we can offer cure for a very important virus, which is a silent virus. And at a national level, we're aiming for elimination. And it's really important that our primary care colleagues are aware of this, can play their part in this, and most importantly, help us to find the final patients. And the idea of inclusion health and prevention of liver disease, I think, is something that's going to move very much more into a primary care environment, which is why we're delighted to talk to you, Charlie.
Well, it's great to have you here. And Rick, we're going to circle back to your role as a clinical champion, because I want to hear more about that.
Yeah.
But Kosh, maybe you could kind of frame this discussion a bit for us and tell us a bit about, the background of what hepatitis C is and how common is it?
So hepatitis C globally would previously be termed a pandemic. Historically, we had a condition called non-A, non-B hepatitis, and work in the late 80s, particularly by Charlie Rice, Harvey Alter and Michael Houghton, led to the identification of hepatitis C, which is a small flavivirus and a new virus. They won a Nobel Prize for that work in 2020 because that started off the identification of that, and then the long duration it's taken us to get to therapies. We'll talk about those treatments that are curative treatments in a bit, hopefully. But at a global perspective, there are places in the world that have had prevalence rates of up to 15%, such as places such as Egypt. There are still parts of the world, such as Russia and China, where it's between 3 to 4% prevalence. Again, screening data is sparse. But I really want to focus on the UK, and estimates tell us roughly, originally before we started with our program of curative therapies, between 0.8 to 1%. But now that's decreased to about 0.4%. So in the last 5 years, we've cured half of the patients who have hepatitis C, and we believe that there is about 50,000 patients left in England to find and cure, and then potentially we'll be one of the first ramp of patients to achieve elimination. And the last thing to highlight, Charlie, is that there is a WHO mandate to try and get to elimination. And again, the good news is England and the UK are in the first tranche of countries to hopefully achieve that. But even more importantly, the Department of Health has made this very clear statement that we will not wait till 2030, but we will achieve elimination by 2025. So a huge kind of step forward and a commitment. And I feel we're on track to achieve that in 2025. But we still need to keep our eye on the prize, and we really need our primary care colleagues to be aware of this and to hopefully contribute and to improve the health of everyone's patients.
I think it's amazing that we're talking about a condition that we are aiming to fully eradicate. It is quite incredible to think about. Kosh, can you talk to us a bit about some of the risk factors for hepatitis C?
There are the traditional pieces, and there's something about recreational drug use, particularly IV drug use, that is very efficient as a mechanism of transmission for hepatitis C. We're seeing now more areas of the world where maybe non-sterile medical practices have contributed to the spread of hepatitis C. I mentioned in passing Egypt with that very high prevalence historically, but amazingly, they're on track to control and eliminate hepatitis C, a huge government undertaking. And their major burden of hep C arose from actually mass vaccination for schistosomiasis many, many years ago, and using one needle in villages and unfortunately spreading hepatitis C very effectively. So the common risk factors, I think you're asking me, are really associated with a history of IV drug use, anyone with abnormal liver function tests, anyone who has had a blood transfusion before 1989 and 1991, blood transfusions and medical products and liver transplants and other transplants. And of course, there is a huge issue about the infected blood inquiry, which I think is going to kind of really change the landscape for us. And anyone with any risk factors and anyone with any other bloodborne viruses. So really the threshold for testing now should be very low because we have such effective curative oral therapies with no side effects. And lastly, it does link to a degree of deprivation. So those patients who may have more challenging lives, who may have more issues, tend to not focus and interface well with models of care. They may have that lifestyle that leads them to certainly recreational drug use, and that may increase their incidence in those populations. So really Eastern Europe, Asia, and a risk factor, but pretty much, anyone with abnormal liver tests should be considered for screening for hepatitis C with an antibody test.
Thank you so much, Kosh. That's a really good overview of risk factors. Rick, can I ask you, as a GP sitting on the front line, can we translate that into who should we be thinking about testing for hepatitis C? How would you approach that? And who would you be thinking, getting your spidey sense going, thinking, where, maybe I should test here?
Absolutely. So I think, as Kosh mentioned, those abnormal liver function tests, I think we have to be thinking about. We do lots of these on a daily basis. So even mild derangement in liver function tests, we should be thinking about hepatitis C. Thinking about where you work. So, there will be GPs listening who work in areas of high deprivation. And as Kosh mentioned there, you will have a large set of patients who will be at risk of hepatitis C. So really thinking about that when you are doing blood tests and trying just adding that on opportunistically. And again, any patient that presents with non-specific vague type symptoms, which is commonly how hepatitis C presents, so malaise, non-specific abdominal pain, nausea, be thinking about hepatitis C in your screening investigations. And again, of course, just thinking about your demographic of patients. So if someone comes into you, as we all do, we look at their past medical history, their ethnicity may be relevant, where they're from, and using that to guide investigations. But I think just trying to keep it at the forefront of our minds is really important, and will increase the numbers of patients who are tested, which is crucial.
It looks like there's a large number of people that we really should be suspecting this in. Now, if we are suspecting that a patient, we want to start to investigate them for hepatitis C, how would we start doing that in primary care? Rick, do you have thoughts? What would you do next?
The great thing about hepatitis C is the testing is very straightforward. So it's a simple blood test. So essentially what we're looking for is a hepatitis C antibody test. If that comes back positive, that suggests they have been exposed to hepatitis C. And the next step would be to do an RNA test, which tells us whether that person is infective. And then it would be signposting or referring on down your local pathways for treatment. But I think, as Kosh mentioned, there are patient groups who are difficult or more difficult to engage with. So as part of the elimination program now, there's a self-testing portal that's been created, which we can send you some information on, which you could maybe put in the show notes, where actually practices can have information up in the waiting room or in clinic rooms where patients can scan a QR code. It takes them to a self-testing portal, and actually they get a home self-testing kit, which they can then use, and then obviously the result will be actioned appropriately. So those are probably your two main ways of increasing that testing.
That's great. And Kosh, do you have anything you'd like to add to that, and also to kind of referral pathways and processes once you've picked up hepatitis?
The key piece that I would say is that historically the RNA test, which tells us if a patient has got active viremia, was limited because of its cost. But I can assure you that now labs should be iterating from an antibody test that's positive to going straight on to doing an RNA test so that you can identify those patients with viremia. And now we have treated a significant tranche of patients and cured them. We're seeing more patients who are antibody positive who are RNA negative, i.e. they've been exposed, they may have been treated and cured, and now probably about 50% of patients are in that group. But so it's much more important for us to focus on those patients who are RNA positive, i.e. that they have the virus, and they should then be linked into treatment. And Rick has very nicely identified the sort of pathways of linkage. Of course, linkage to care is critical. I think the other piece of this is the operational delivery networks which run across England, who are responsible for the commissioning of treatment and the delivery of treatment and are funded to do that. So what we've done is we've taken this condition now from a complicated in-hospital treatment of over a year with interferon now to completely out of hospital, in drug and alcohol, in GPs, in patients being treated where they want, and really with very simple ways of and very user-friendly ways of identification, even using oral swabs, point of care testing, but as Rick has alluded to, a very nice web portal for patients who can have that test, and automatically, if it's positive, that result will go to the GP and to the local lead, who will then go out and find that patient and contact that patient as part of the team to get them into treatment. So of course, diagnosis is only one part. We need to deliver treatment, and we will hopefully kind of touch upon that. But the whole pathway needs to be as seamless as possible.
You've segued nicely into treatment, and I do want to ask you about that. But before I do so, could I just ask, perhaps Rick, what happens if we don't identify these people? What are the potential complications of hepatitis C?
We know that if left untreated, it significantly increases risk of fibrosis, cirrhosis, and hepatocellular carcinoma, which all have significant cost associated with them in terms of long-term care, but also impacts on primary and secondary care. And then, of course, liver transplant as well. So this is why we really need to identify and treat these patients early. And I think Kosh obviously sees those patients in secondary care, so it'd be interesting to hear what he thinks.
Yeah, no, thanks, Rick. It's a good question. So liver disease is silent. And liver disease generally is modifiable and preventable. And lastly, 80% of the healthcare costs for liver disease currently accrue in the last 2 to 4 weeks of life. So when someone presents with jaundice and liver failure and ascites, that's way too late. And actually, you're both very young, but in my life as working at King's in a transplant unit, I'd say 10 years ago, maybe up to 20 to 25% of the transplants we did were for hepatitis C. And guess what? Hepatitis C used to come back after we did a liver transplant. We just reset the liver. We now don't see hepatitis C at all as an indication for transplant, but this is a longer term virus that sits in the liver, chewing away at the liver, and can increase very much, as Rick has said, the risk of cancer, the progression to cirrhosis. Obviously, it's an infectious disease as well, bloodborne virus, so there's a risk of transmission. So at all levels, fitting in with the whole kind of umbrella of liver disease, early identification and early treatment is important for patients and important for the healthcare environment in toto. And then just to add into that, it's interesting to note that in the last week, liver disease has now sat onto the NHS transformation piece alongside with renal to now start to be a bigger piece to start to move that dial into a more prevention and early identification piece. And this has been led by, I think, the really interesting and delivery work from the world of hepatitis C.
Totally agree. Huge amount of liver disease out there, and it is very silent, and it's something we need to be identifying. And when you talk about those complications, hepatocellular carcinoma, liver fibrosis, these are hugely transformational issues for patients to develop. So we need to be identifying early and managing. So it's good to hear that it's on the strategy and it's there as something we need to be aiming towards. Kosh, can you tell us a bit about the treatments for this virus?
We're a bit blasé from my end about treatments, and again, it's a surprise to see where we've come from. When I started as a consultant, we would be treating patients with hepatitis C with the year's worth of interferon therapy, with very significant side effects, with only a 20% chance of cure. Really, the world changed and it transformed around 2015 to 2016 with the advent of classes of drugs called directly acting antivirals, so DAAs. Interestingly, for a virus, you don't need to modulate the immune system. Actually, hepatitis C is actually is a little bit of a weedy virus, and actually, if you can knock it down very quickly with very direct acting virus drugs, after a short period of time, you can get to clearance. It doesn't hide in sanctuary sites. So the current treatments we have are those drugs combined, different classes of drugs that I don't think really are, would be helpful to go through and frankly, we have all forgotten. But in essence, they're combined in 2 or 3 different combinations. They may be 1 pill a day for 12 weeks or 3 pills a day for 8 weeks. Oftentimes now we really don't even need to know the strain of hepatitis C, whereas before we had to be very genotype specific. Now we have pan-genotypic drugs. And I sound like a bit of a fanboy because I was involved in some of these clinical trials, and it's amazing to have this in clinical practice. But really, these treatments are so simple. They are 8 to 12 weeks. They have very little in the way of side effects. We don't even need to monitor patients. We can give them 12 weeks in one go. They are probably effective enough that if you take more than 4 to 6 weeks of that regimen, maybe 50% of it, but we always ask our patients to take the full regimen, it's going to be effective. But our cure marker is to see those patients 3 months after they finished and to see their sustained virological response. And across the piece, whether you have end-stage liver disease, whether you have HIV and hepatitis C, whether you have comorbidities, whether you have haemophilia, whether you are pediatric, adolescent, whether you've had a transplant, we're talking about 96 to 99% cure rates. With other treatments, if by chance you fail, and oftentimes I'd say 90% of the time a failure nowadays is related to concordance or not getting the drugs or anything else. And just to give you an idea of how effective these treatments are, we now have moved from transplanting from hepatitis C to now consenting patients for solid organ transplantation of all sorts for hepatitis C organs, so they can get a transplant if it has hepatitis C, and we treat them as they come out of the transplant, whether it's lung, heart, kidney, liver, and we give them a course of therapy. So it's really, the treatments really are, the engine of this, and cannot be easier, cannot be better. They are, wonderful treatments, I have to say.
It's incredible, and actually I could just hear your excitement about those medicines, and that cure rate that you sort of provide there is phenomenal. It really is incredible, isn't it? So it's something that's eminently treatable if we can find those patients. And that does bring me back, Rick, to wanting to ask a bit about your GP champion role. So I want to hear a bit more about your hepatitis C GP champion role. What are you doing within that role, and
absolutely,
and what's happening there?
So I've really enjoyed it thus far. I think my role is multifaceted. One big part of it is education. So across the primary care workforce. So, going into practices, speaking about the work that we're doing, educating them on hepatitis C. Also engaging with trainees, so in the kind of VTS programs, going into them, providing education. Obviously coming on your podcast is part of that, which I really enjoy. It's also then at a local level, so supporting practices and PCNs and using sort of GP federations to run searches. So this search has been designed by the Hepatitis C elimination program. So it's a very straightforward search embedded on EMIS, which can be run by practices or PCNs or GP federations to identify patients who have risk factors coded that will be picked up on the search. And if we can run that search, it can then get shared with the ODNs in whichever area you're working with they will go through that search, look at it, and contact patients if needs be. If they have been lost to follow-up, they'll try to re-engage with these patients. They will offer testing if they're at risk of hepatitis C. So that's a part of the work that I'm doing currently, and we're looking at the area that within the area that I'm working in is to run it at a GP federation level. So I think that's a really effective way of getting this done. I think the other things that we're doing as GP champions across South East London is collaborating with local healthcare organisations, and I think that's a really interesting piece of work, and actually really shows how healthcare, I think, should be delivered. So, for example, I've recently worked with one of the homeless linked charities in Bexley, which is where I work, and also the drug and alcohol services, and obviously the ODN itself, to plan for our testing bus, which comes from King's College, to go into areas which have high prevalence of intravenous drug use and deprivation, and offer opportunistic testing to people who might be at risk. And I think that's the type of work that we're doing as GP champions, which I really enjoy. And I think another part of the work that we're doing is looking at those pathways that Kosh mentioned and making them as seamless as possible. We know that from a GP's perspective, we want clear pathways. We want to be able to know where to refer someone if we get a positive test, and that's some of the work that we've been doing recently to improve that pathway to get patients into getting treatment.
I think if you were to be a bit pokey, Charlie, you'd say, well, why are you only doing this now when you're sort of 5 years into this program? Why didn't you involve primary care earlier? And I think that's a very fair question. We have always been, the national team have always been very aware of the pressures that primary care have been under. And all of that was really ramped up very significantly within the COVID pandemic. And I think it's the right time to have now 65 nationally GP champions who really are our ambassadors to go out to highlight the opportunity of inclusion health, looking back on those patients who might have been tested previously but have never been referred because people felt the treatments weren't very good, that historical piece that I gave you when there weren't very good treatments. So I think there is a massive education piece for the GP champions, and we're very, very lucky to have formidable colleagues in primary care in South East London. We really are urging our champions now to do those searches and to show those linkages, because the real bite in this is that in the next 2 years this will devolve from a specialist commissioned piece into business as usual. So we need our primary care, PCNs, ICBs, public health to sort of get to maintenance and starting to almost take this on board alongside liver disease as an important part of prevention and sort of primary care work. But we're really pleased to have Rick and others across London and nationally, and in some areas, and I particularly want to cite this, almost 80% of the patients now are being found from our GP champions. And so that's really impressive work already, that going into other surgeries or encouraging colleagues to do these searches is now finding those patients that we can't find in the normal way. So this is how we get to the real knockout phases of getting to elimination. So we're really pleased to have the likes of Rick and others helping us and really putting their efforts in.
Sounds fantastic. And if I'm a GP in my area and I want to find out who's my nearest hepatitis champion, is there somewhere I can go to do that? How would you recommend us engaging, as general GPs with these champions who are national?
That's a very careful question, Charlie. I like that. So I would suggest that in the show notes, I will give you the list of ODN leads and their email addresses. And they probably are the best first port of call to talk about where the GP champions are. Of course, these run alongside predominantly in London, and I'm sorry to be London centric about this particularly, about the HIV champions, where HIV is a major issue for certainly some parts of the country. And I do really urge us, and hopefully we're going to have some useful discussions offline, that this prevention part of hepatology, to develop a niche for primary care, to have that sort of interface to decrease the referrals, the lifestyle management. I will really highlight not just the sort of specialist transplant world, but the identification and treatment for somebody who really is homeless, can really change their lives with regard to someone that's actually bothered to help me, and then brings them into inclusion health and just generally gets them engaged. So the idea that you can offer something, you can give them something to cure a condition, it can really change people's lives. And I don't want to sound sort of cheesy about it, but I've seen it, and it is really something we should celebrate. And it's not people like me, it's the nurses, it's the drug and alcohol team, and most importantly, our stakeholders in the Hepatitis C Trust, which is a patient charity commissioned and that delivers a lot of the work that I've been talking upon.
Rick, Kosh, I've really enjoyed talking to you about hepatitis C, and your enthusiasm and energy is great. I want to go out there and try and find patients who potentially have hepatitis C. I'm engaged. I'm on board. You've sold it to me for sure. So I'm really interested. At the end of these podcasts, I always ask our speakers to kind of give their key take-home messages for our audience. So, Kosh, Rick, what key messages around this topic would you really like our audience to leave with today?
Firstly, we can make a real difference. in primary care, and never underestimate the impact that we can have as the primary care workforce, specifically related to hepatitis C. It's more common than you think. It's curative. There will be patients in your practice that have it, and it's about thinking about hepatitis C and using all the resources that we've discussed today to get those patients the care that they need.
Brilliant, thanks. And Kosh, the final words.
Not a lot to add to Rick. I would just say that hepatitis C is an exemplar of joined up and collaborative working, which has really put patient benefit at its forefront and has delivered real metrics at a societal and population health level. That hepatitis and liver disease in general shouldn't be something that our primary care colleagues should be afraid of, that there's support there, and that liver conditions can be treatable and preventable, but particularly hepatitis C is curable, and we really encourage the identification of patients and linkage into care, and we really value our primary care colleagues in delivering this.
Brilliant. On that note, I'll say thank you so much for joining us, Rick and Kosh, and thank you very much to our audience for joining us. I hope you found it really interesting. I certainly have. Thank you. Well, it's been really great to talk to Kosh and Rick there. Lots of energy, enthusiasm, and loads of really helpful information about hepatitis C virus there. So lots and lots of really useful take homes from this episode. But my key take homes that I've taken from this discussion are, firstly, that there can be a really varied presentation with hepatitis C. So we've got to think about it with those abnormal liver function tests or vague, non-specific symptoms that we can't otherwise explain. And we also need to really keep in mind those risk factors that Kosh and Rick have both talked about during this episode. My second take home was around testing. It's really simple to do. We do a hepatitis C antibody test, and then the RNA test will tell us how infective that person is. And then finally, my third take home, treatments are really effective. Kosh was saying 96 to 99% cure rate with actually relatively short and simple courses of treatments with tablets. So lots to take home from this episode. I hope you've enjoyed it, and I look forward to talking to you again in our next episode of Ingest. Thank you very much.